So we had in 2006, and we introduced this initiative, and we went to 10 liver clinics in the public hospitals throughout Queensland. There are also 3 other smaller ones that are coming on board. We were one of the first states in Australia to develop this. The staff who deliver this care, those first 4 dot points, they're all the staff that are located at the liver clinic in the hospital. The GP is out in the local community, which provides all of those people who are living in all those rural and remote areas and those one-street towns with access to their GP, which is one of the benefits of the program. I'd like to draw your attention to the triangle in the middle of this diagram. How does this model of shared care work? In essence, if you take away that triangle in the middle, which is the nurse care manager, the program won't work. It will fall apart. What we found in our pilot, and we've found over the last few years, is that that nurse manager is intricate and they're the linchpin to this program surviving. Basically, they coordinate all of the care that goes on, the patient in the community with their doctor, they have input to the doctor, they talk to the patient, they get the patient coming in at the times they need to come into the hospital, they make sure that the local doctor and the specialists at the hospital are communicating as well. As you can imagine, all the blood tests and liver tests that have to be conducted, the timing of those is very important. All of that has to flow very efficiently. This model supports a continuum of care. So basically, right from the beginning, when we have the preparation and assessment of the patient, the nurse manager is involved. What we have in Australia is a very rigorous preparation and initial assessment. They have a psychological assessment, and basically, if they're not ready for treatment, they won't be allowed to go on to treatment. That can take, in some cases, up to 2 years, but it's important. And what we know is that once they're ready and once they access treatment, they often move through and complete treatment. There are a lot of support networks that are put into place for these people with undergoing treatment in the shared care model. So what are the key elements? What do we know works with this model? It's patient-focused. The main thing that we found out with this is that we all know, and we've all heard on many occasions, that the treatment is arduous. It's not a walk in the park and it's not a lot of fun. For a lot of these people in Queensland, what compounds a lot of this is that they live in very isolated areas. So on top of not feeling well, to get in a car and drive 6 hours to a major hospital and then back again is almost sometimes a bit too much. If they can go to their GP down the road, it's much easier and much more doable. So what we also know is that a very key element of this is that we have joint cooperation and participation between the local doctor and the team at the hospital. And the nurse manager, again, keeps that information flowing and makes sure that things work properly. The communication and a clinical pathway are both things that underpin the success. The clinical pathway is basically modifiable. Some smaller hospitals have a protocol that they might alter slightly. The larger hospitals have a protocol that they pretty much adhere to. I don't expect you to read all of that. What I'd like to draw your attention to is the blue column. Before we implemented a shared care model, basically every person that was undergoing treatment and care would have to go to see a specialist at one of the major tertiary hospitals. As you can see now, a lot of those trips can be to a local doctor, and that has enormous benefit for a lot of these patients. It's often the difference between whether they will go on to treatment and whether they won't take up treatment. In implementing our model, we put in place a lot of training for the health professionals, in particular the nurses. The nurses have maintained that network. We have regular communication with them as well. And the nurses have a lot of input and a lot of visits and consultations with the GP to make sure the GP is comfortable and that they're working well through the model. We've recently just conducted an evaluation, and it actually, the first presentation of it commenced on the day that I left. We had an independent university conduct the evaluation, and I'd just like to draw out some of the glimpses of the feelings that nurses and some of the other team involved in the program have put forward. This nurse is highlighting, again, this issue of travel and the time associated with it. You can imagine getting in your car and driving for a large number of hours, getting to a hospital, 5 or 10 minutes with the doctor, getting in the car and driving all the way back again. And she's highlighted here that that's been a major issue for a lot of the people that she sees. The shared care model, I'm not going to say it hasn't had its problems and hasn't got still a few warts around it. Some people living in those small towns don't want to go to their local doctor. They don't want it to be known, and they don't want people at jungle drums to spread around the town that they're being treated for hepatitis C. Also, some GPs aren't comfortable with treating people with hepatitis C. So in some instances, we've had these people that don't want to participate in the model. The gastroenterologists, some of them were quite anxious about the model. They didn't want to lose control of their patients. They wanted to keep them coming back into them in the hospital. Others were more willing and more accepting of the model, and they also realised the benefit for the nurse and the benefit that it was having with the patient. The patients themselves, a large majority, 75%, were happy with the program. There were, of course, always some people that weren't that happy for various reasons, and there were some people that declined to comment. This patient basically highlights exactly what we wanted to achieve with the model. They felt that the GP service and going into the hospital was good, and that was a great team and it worked well, and again the role of the nurse was highlighted as being important. So what are the elements of a successful model? Basically, as I've mentioned, it's client focused. We know that to get these people all the way through, they need a lot of support and a lot of care. The nurse case manager, again, very, very important, pivotal to this whole model working. The clinical pathway, we know that has to adhere to a certain number of protocols, etc., but that can be flexible as well. We need to put training in place to assist people with implementing the model, and there also has to be a great willingness of people to participate. We need to provide resources and education for all the stakeholders. So how many people have we treated? We started off with that baseline of approximately 200 patients per year. We haven't quite achieved our goal of trebling the number of people on treatment, but we're getting there. You might query why there was a nice rise and then we had a decline there in 2008. We think that was a lot of people, the specialists were putting them onto clinical trials. We're not quite sure. Nonetheless, we're on the up. So the benefits of the model. It basically benefits a lot of people in terms of the level of support that they get. They didn't have this before. They didn't have a nurse manager supporting them. They didn't have access to dietetics, issues to do with any alcohol use, and now they do. The quality of care is greater, and there's greater access for treatment. The waiting times on the whole have declined, and we know that there are a number of people, more people going through treatment, and the overall coordination and care is better. What did it cost us? This is always the nasty bit. The pilot, $100,000, and then another $40,000 for an economic evaluation or analysis. There are about $250,000 in start-up costs. Our recent evaluation was approximately another $90,000. $1.6 million is ring-fenced, and annually that goes to the 10 liver clinics. Community support. We fund a lot of organisations to provide support to these people. If they're not able to get in touch with the nurse manager or their local GP or the hospital staff, they're able to ring the Hepatitis Council of Queensland. They provide a range of support similar to a lot of the organisations here. Here's some of the staff putting a bit of a face to programs and things here. They don't all lie down on the job. That's Jake. He likes to have a bit of fun. This is them on a road trip. They're paying a bit of homage to one of Australia's recent icons. And I think they've got another stop along the way here. You probably think it was the best job in the world, but maybe the surfer has the best job. So we have community support as well that we provide to our Ethnic Community Council of Queensland. I've highlighted the ethnic mix that we have in Australia. They play a very, very crucial role in making sure that anyone from an ethnic background understands what's being conveyed to them, understands what treatment means, and assists them with questions and queries. Our Queensland Association of Healthy Communities, they have an LGBT program where they assist people there with information and resources about hepatitis C. There are other community services as well for people, dietetics and alcohol. So we've established a flexible system of care. We've got a greater number of people accessing services. There's greater satisfaction, and people aren't having to travel and go through a lot of arduous financial I think cost to them when they're having to travel long distances. That's one of the major benefits. We have challenges. We need more funding. We want to put more liver clinics in place. A lot of our gastroenterologists, I think, would agree they're not getting any younger. We need to make sure we've got some succession planning. We need to have more skill development. We need to have more nurses coming through. This is just to keep pace with patient numbers, and also we know that a lot of the patients coming through now have very complex needs. We also have an issue that we need to keep ahead of pharmacy in requests and indications, and we also have pathology requirements we need to look at.